Okay, everyone, I suppose we'll get started. Hello, and welcome to NDARC's weekly webinar. My name is Tom Santo Jr., and I'm a postdoc at NDARC, and I'm thrilled to be able to host today's webinar with Dr. Craig Cumming, who's going to share some of his insights from his latest research on the aspects of the WHO Assist tool, or the Health Organization's Assist tool, which has the potential to predict health outcomes related to substance use post-incarceration. Prior to that, though, I would like to acknowledge the Bejugal people that are traditional custodians of the land on which I'm presenting today and which NDARC is situated on. I would also like to acknowledge the traditional owners of the country throughout Australia, and noting that our speakers and audience are joining from many different locations throughout Australia, as is Craig. And we pay our respects to elders past and present and extend that respect to any First Nations people present today. Now it is my great pleasure to introduce today's speaker, Dr. Craig Cumming. So Dr. Craig Cumming is a research fellow at the School of Population and Global Health at the University of Western Australia. During his career, he's used a range of data resources, including survey data, as well as linked and administrative data, to explore the health challenges faced by marginalized populations, including people who are incarcerated and those experiencing homelessness. Mental health and substance use are critical focuses of Craig's work. And today, Craig's going to be talking about how to use the World Health Organization's Assist tool during incarceration, as I mentioned before, to predict the risk of poor substance-related health outcomes after release from prison. I'm pleased that during the question and answer time, which will be after Craig's presentation, that we'll have the opportunity to hear from our own Associate Professor Rebecca McKenton. Rebecca leads a program of research into stimulant use epidemiology and interventions at NDARC. And Rebecca has a particular interest in researching methamphetamine use patterns and treatment options, and has been involved with the development and evaluation of online self-help interventions, community-based treatment options, and clinical trials of pharmacotherapy options for methamphetamine use. She's been working in the field for about 30 years, and her ambition to improve access to evidence-based care for people who use methamphetamine is top priority. So at the end of the presentation, Craig and Rebecca will take questions from the audience. And so you can log those questions for the panelists using the Q&A function in Zoom. So please use that rather than the chat function. And I'll try to get to as many of your questions as possible during that part of the presentation at the end. So Craig, it's my pleasure to now hand over to you. If you like to turn your mic and camera on, and over to you.
Thank you very much, Tom. And thanks very much for the opportunity to present what are some findings from my recently completed PhD today. So as Tom alluded to, my PhD primarily looked at how the World Health Organization's Assist screening tool could be used in practice in the prisons to try and work out who was at the greatest risk of substance-related harms in the period after release from prison. Just a few acknowledgements before I get started. So yeah, a special acknowledgement to the First Nations people who were a very important part of this project. As we all know, First Nations people are disproportionately incarcerated in this country, and so they make up a large percentage of our sample. Sovereignty has never been ceded over Australian land, so First Nations people remain the cultural and spiritual custodians of the land that we call Australia and that we enjoy today. And I pay special respect to the Whadjuk people of the Noongar Nation, who are the traditional custodians of the land where I'm presenting from in Perth today. So just another acknowledgement for partners of the research, the WA Department of Justice, Queensland Corrective Services, WA Department of Health, and the AIHW, who all provided support and data for the project. Obviously today's talk, what I'm presenting today is not endorsed by any of these people, so any errors of omission or commission are sole responsibility of me. Also, I'd like to acknowledge supervisors and co-authors. Tom's already mentioned Rebecca, who's online today with us, my primary supervisor, David Preen, Stuart Kinner, Ian Lee, and also Jesse Young, who was a co-author on a number of the papers. And an unofficial co-author is my dog Biffy, who was by my side when I was writing my thesis for pretty much the whole time. Also, a special acknowledgement to the people who participated in this research. Obviously, there would be no project without people who were graciously prepared to sit down and chat to us, and also provide us access to their administrative data. Without them, there would be no project, and hopefully our work can in some way contribute to better outcomes for those people, but also people in a similar situation to them in the future. Okay, so just a bit of an outline for today's talk. So I'll go through a bit of a background that sort of informs the body of work that I'm going to present, including the current evidence, a systematic review that formed part of my PhD, the health characteristics of people who go in and out of prison, and then we'll have a look at a couple of papers that investigated how reliable the assist is as a predictor of subsequent substance-related outcomes. And then I'll just briefly recap and go through some findings and conclude, and then I'll look forward to hearing questions and comments from the audience today. So just a bit of context about how I kind of ended up here. I was originally a law student and got recruited to be a research assistant on the JUMA project, which some people watching today will probably know. So Drug Use Monitoring Australia is funded and run by the AIC. I was working in the Perth site from 2011 for a couple of years. It was my first research job, and I didn't really think that research would be a career. I thought I'd be practicing law. But it involved us 4 times a year going into the Perth Watch House, and this happens all around the country in the major cities, so in Sydney and Melbourne, etc. And we would sit down with people who'd just been arrested, ask them a series of questions about their drug use and about the drug market generally, just to get a sense of drug use patterns and costs, etc., along with asking them for a sample for your analysis. So we saw all sorts of people in all sorts of states come in. So really was a really eye-opening experience, a bit of a baptism by fire. So I saw people at the start of the justice kind of journey, if you like, so before they've even made it into prison. And then I got referred to another project to be a research assistant interviewing people who were within 7 days of being received into prison. A study that was run by Dr. Sophie Davison, who is a forensic psychiatrist who now sits at the Mental Health Commission here in Western Australia. So this was really a mental health focused study that also covered a little bit of substance use as well. And then the project which I have actually done my PhD as part of is the health after release from prison. So the other end of the prison journey, when people are about to get released from prison, we sat down with people for an hour, give or take, to go through a range of things, and I'll cover the sort of data that we were collecting a little further in my talk. So what do we know about this population and about people who move through prison? So substance use resumes pretty quickly after people leave prison for a lot of the time. And along with that comes a lot of poor related outcomes. Obviously the most serious being death, overdose death usually. Opioids is a big driver of that. And injecting drug use and those sorts of things frequently occur, in that period after release from prison. So we kind of know this. This is work that some of my colleagues have done and others over in the States. We also know that methamphetamine now is only behind cannabis as the most prevalent drug used by people entering prison. So almost half of people who go into prison now report using methamphetamine in the 12 months before prison. We know that courtesy of the AIHW and their routine data collection. However, to date, opioids have been a big focus of research in this area. There's good reason for that, because the outcomes associated with chronic opioid use and relapse are extremely serious. So there's good reason for that to have been a really big area of focus. However, what it does mean is that we probably need a bit more data on methamphetamine, given how prevalent it is now. So to that end, the first task that I undertook as part of my PhD was to do a systematic review, to look at what happens to people who've got a pre-existing history of methamphetamine use, who then go on to have contact with the justice system, and then what happens to them after that contact with the justice system from a health and criminal justice system point of view. So not a lot of data here, not a lot published in this area. As you see, there's only 9 studies that met the inclusion criteria. 5 of these looked at health outcomes and 4 looked at justice outcomes. Key findings were that justice system contact, methamphetamine use was associated with drug-induced psychosis, recidivism, and increased crime costs, but it wasn't associated with non-drug-induced psychosis, and it also wasn't associated with post-release mortality, which obviously is a point of difference to opioids, which are very heavily associated with post-release mortality. So that's one key difference emerging there. So that brings me to the health after release from prison study, which I led the data collection and recruitment with a team of interviewers. We went into the prisons in Western Australia. Queensland had already started the process by doing their recruitment and data collection a few years before us. We essentially just mirrored the Queensland study so we could end up with a larger combined cohort. The research is ongoing, and we're about to add cohorts from Victoria and New South Wales, which are similar in nature and similar in terms of the items that we asked and that sort of thing. Well, the items that they asked, I should say. I wasn't involved in the data collection for those. But yeah, we're going to expand the study to be 4 jurisdictions instead of 2. Just gives us a bit more statistical power and obviously coverage across more of Australia, so more generalisability. But yeah, that's exciting that that's currently happening as we speak. So just a brief snapshot now. Today I'm going to cherry pick some key findings from my research, but I'm happy to talk about anything that people may want to ask, whether it's during this session or after, because I can't get through everything in a brief session. But yeah, please feel free to, if there's anything that comes up today that I haven't mentioned, please feel free to get in touch. But anyway, so for people to be eligible for our study, they needed to be over 18, needed to be sentenced. There's sort of specific reasons for that, because in Western Australia, for example, people who get sent to prison for not paying their fines, and they tend to cycle through in a few days. We're not really interested in that population. It's more people who are in prison for a while where there are opportunities to intervene and provide treatment. Needed to be incarcerated for more than a month for similar reasons, and also needed to be within 6 weeks of expected release from prison. Now, sometimes things change and people have unresolved charges that maybe get brought as they're getting ready to leave. But our intention was to try and get people who were going to be leaving prison within 6 weeks. They completed the baseline survey upon recruitment. Broadly speaking, we looked at social determinants such as, family history, employment, education, housing, that sort of stuff. We looked at their health in great detail. So that was, chronic disease, and also mental health and AOD was a key focus of the project as well. So we asked a range of questions about that. And then also asked them about what they expected to happen post-release. So yeah, just a sort of an overview of our data sources graphically. So you can see the baseline interviews were completed in both jurisdictions. Now in Queensland, they went a step further and did follow-up interviews after release. So these, I think, occurred over the phone at 1 month, 3 months, and 6 months. Now, not every person did every interview, and there weren't, there were some participants that they couldn't follow up, which is quite common and a bit of a challenge with prison-based research. But we did get pretty good coverage. I think around 80% did at least one of those follow-up surveys. We didn't do that in Western Australia for resource reasons, but those follow-up surveys gave us some pretty rich data and interesting data to work with as well. And then from both jurisdictions, we had linked data. The list is a lot more extensive than what I've listed there, but this is just what I used for my PhD. So ED data, hospital data, corrections, and death records for censoring purposes. And so some of the key measures that were included in my PhD was the ASSIST, obviously, because that's sort of a key focus. And then the ESSI, which looks at social support, which we know is an important factor in people reintegrating into the community successfully. And then the K10, which is a simple, brief measure of psychological distress. And also there's been a lot of work done that to suggest that the K10 may be indicative of serious mental illness and other things as well. So it's quite a useful, brief tool. So yeah, just a bit more on the ASSIST. So it's a fairly simple tool. So it's 8 items. That's 8 items per substance that you're interested in finding out about. So you would repeat those for each substance that you're asking about. Assesses for low, no, moderate, and high risk based on the score that's generated. Now, this was developed some years ago when the DSM-4 was still being used before the DSM-5 had been introduced. So moderate use loosely equates to the old substance abuse classification, and high risk substance use loosely equates to dependence. Obviously, those classifications aren't really used in practice anymore. It's all under the umbrella term of different levels of substance use disorder. But yeah, there is some literature showing that there's good retest reliability in prisons, and it's a lot quicker and easier to administer than some of the other screening tools in this space, like the SCID and the CIDI and whatnot, which take quite a bit longer. And you don't need to be a trained clinician to use the assist. It's fairly easy to train someone how to use it. So that was one of the reasons we were using that in the prisons. So that brings me to my first original paper of my PhD, which was because I was interested in looking at methamphetamine use compared to opioid use, which we know a fair bit more about opioid use now. I thought it'd be interesting just to compare the profiles, like the health profiles and the health needs of people with a history of methamphetamine use with those with an opioid use history. And also there's a group that you'll see in the results that actually use both. So I thought it'd be interesting just to get a sense of what their health needs might be. You can see here, similar to the AHW data, methamphetamine is the most prevalent. Opioids was our reference group because we're using, that's the group we know the most about. And then there's this group that sort of crosses both methamphetamine and opioids, which you see from the sample size there is, roughly 3 times that of the opioid only group. Some of the sociodemographics and health that we looked at, so age, sex, indigeneity, risky behaviours, which included injecting drug use, included unregulated tattooing, unprotected sex, so anything that might carry a risk of disease transmission. And then mental illness was another thing that we looked at and compared between these groups. So just a snapshot of the data that we used. This was a cross-sectional study, so we just used the baseline interview, so these were self-report measures and items. Key findings, so methamphetamine only group tended to be younger, so under 25, more likely to be under 25 than the opioid only group, more likely to be Indigenous than the opioid only group, but less likely to have been in prison before this current sentence, were less likely to have injected, and also were less likely to have overdosed, which kind of is consistent with what we know about opioids being, a huge risk for overdose. But overall, though, rates of injecting were still very high across all groups. So methamphetamine only group was 79%, and then it just went up from there for the opioid and meth group and the opioid only group. So pretty high rates of injecting. More than half reported a mental illness diagnosis at some point in their life. Almost 60% had moderate to high distress on the K10, so pretty high rates of distress there. More than 25% attempted suicide, which is obviously quite a concerning finding, but also interesting in that I think it was around 18% reported self-harming. So it was actually a greater prevalence of suicide attempts than self-harm amongst the group. But that has to be contextualised. A colleague of mine, Ryan Borshman, had done some work to show that self-report of self-harm tends to be fairly unreliable, and it's routinely underreported. Hepatitis C prevalence, 29%, which at the time is around 18 times the general population. Once again, this needs some contextualisation in that when we were recruiting for this study, I think it was just before or just as the new treatments were coming in for hepatitis C, which were far better and more reliable than the previous treatments. So I would anticipate that if we redid this study now, that hep C prevalence would probably be a bit lower, because I think more people are getting access to those drugs in prison and getting successfully treated now. So yeah, just a few sort of brief and interesting findings comparing the sort of profiles of those two groups. Well, there were 3 groups, but primarily opioid only and meth only. Now, I should say that with the assist, and I forgot to mention this before, although we were administering the assist at the end of someone's prison term or prison sentence, we were actually asking them to go back and think about the 3 months before they came into prison, because that's the period of time when we were most interested in knowing about their substance use patterns, was that time before prison. Obviously, once people come into prison, their opportunities and probably motivation to take drugs diminishes somewhat. So a lot of people end up ceasing use once they enter prison. So anyway, it sort of led me to think, we've got all this great data on the assist for a range of substances. How useful would it be to know whether the assist could be used to predict what happens after people get out of prison? So based on their previous, pre-incarceration drug use patterns, how strong a predictor is that of what happens when they get out? And it could be a marker for people who may need a little more support. So that leads me to the next paper, which was published in Addiction in 2023. So we wanted to test the predictive validity of the assist for moderate to high risk cannabis, methamphetamine, opioid use after release from prison. So you can see here, we're looking at relapse in that period after release from prison. The reason that we chose these substances is that these are the most prevalent according to the AIHW surveys and also our own data. So we thought they were the ones of most interest. So yeah, here's a snapshot of the data that we used. So we restricted our sample to the Queensland participants because they were the ones with the follow-up surveys. So WA, we didn't do that. So we just stick with Queensland for this paper. And so, as I said, we looked at substance use in the 3 months before prison. And then in the follow-up survey, it was a much simpler couple of items that we used. So we followed up at 1, 3, and 6 months. We actually just combined all of those together. So if someone reported any use of each of those substances during any of those surveys, then they were coded as having used that substance in the first 6 months after prison. And then the weekly or more use binary variable, we also asked people on how many of the previous 28 days they had used that substance. And if they had reported at least 4, then we coded them as having weekly or more use. Obviously, that's not a perfect marker for weekly use because they could have used on 4 consecutive days and then stopped. But we just took that approach, in the interest of being pragmatic. So we had 1,054 people once that met the inclusion criteria, so they needed to have sufficient exposure data and sufficient outcome data. That's a pretty good number considering how difficult it is to follow up people who are released from prison, and some of those people were re-incarcerated and got followed up back in prison again. So the proportion of participants, you can see there that in the moderate and high risk categories, cannabis, so cannabis had the most overall, if you combine those two together. Methamphetamine next, and heroin and other opioids, consistent with the other data that's out there. And then this, sorry, so this, I should say, this is relating to the 3 months prior to them coming into prison. This is the post-release substance use. So you can see there that just over 40% use any of these 4 substances at some point in that first 6 months after prison. And then you can see it's broken down there by the type of drug. Once again, cannabis being the most prevalent, and then methamphetamine, heroin, and other opioids. So it just gives you a bit of an idea. Quite a large number of people go back to using substances fairly soon after release from prison. So this is where we did a bit of analysis, sensitivity and specificity. Also used Uden's index to generate the optimal cutoff score. So this is where the score that's furthest from chance on the area under the curve. You can see there that the cannabis, methamphetamine, heroin are fairly useful, but other opioids, it's questionable whether this tool could be used for that, given that the optimal cutoff was 0. You can also see there that the area under the curve, so between 0.7 and 0.9 is said to be moderately accurate and moderately useful. Obviously over 0.9 is extremely accurate, but as this is a screening tool, this is a pretty good result. Sensitivity also pretty good for just a simple screening tool. And then in addition to working out the optimal cutoff, there are established cutoffs for those moderate risk and high risk categories that are used in practice, based on the years of developing the assist and testing it. So we had a look at those established cutoffs, which actually in the greater than or equal to 4 is the equivalent of the cutoff of 3, essentially. And then you can see the negative predictive value. There aren't too many people that are incorrectly diagnosed or incorrectly screened as not being at risk, which is quite good, because you'd rather have too many people screened and get offered support rather than too few. And then you can see the high risk results aren't really that useful. That's obviously quite extreme chronic use most of the time. So the findings of that suggest that there is some utility in administering the assist in prison, and it gives us a pretty good idea of who is going to go back to using drugs in that period after prison. The next thing we thought we would have a look at is, rather than just self-reported drug use, whether the assist could discriminate between people who are at risk of substance use that results in hospitalisation. So probably a higher threshold outcome. So substance use that's so serious that it required hospital treatment, either in hospital or in the ED. So you can see, once again, we combine heroin and opioids because there's no ICD codes for heroin as such. They cover all opioids, but we used the heroin module of the assist as the exposure. And then the outcomes were substance-related hospitalisation. Once again, you can see there we used the assist, and then we had access to hospital admission records and also ED presentation records. And there are ICD codes and whatnot recorded with those. So another overview of the data here. This time we could use Queensland and WA, so we had a much bigger sample. You can see there the records that we used, including the justice data as well, because we needed to know if people were going in and out of prison, because we used survival analysis. You can see here just a brief kind of flow chart as to how we ascertained eligibility for the study. Ended up with a sample of 2,585, so quite a bit bigger than the previous paper. These were the ICD codes that we used, and then I also included an any substance category, which was any substance in addition, including these 3, but also in addition to them, any illicit substance that people may have used that may have resulted in a hospitalisation. So we used Weibull regression, repeated events, because people obviously didn't die. Well, there were some, as we saw on the previous slide, that we had to censor for death, but the majority of people didn't die. They could possibly have the outcome again. We had to interval censor to account for reincarceration for the follow-up time calculations. We right censored to account for deaths. We had separate models for each substance, and then we had a separate model for the any substance category as well. And then we also had separate models for each of those substances at each of the time points. So 3, 6, and 12 months, and then the entire follow-up period, which I'll go into in the next slide. And then, so we did unadjusted and adjusted analyses, adjusting for factors that are known to have to be associated with drug use and drug-related outcomes, based on the data that we had and from previous literature as well. So follow-up time. So this is kind of quite an interesting result. So you can see that the range is extremely wide, and that's likely down to the fact that, unfortunately, there is an acute risk of death in that first couple of weeks after prison. So the really short follow-up time participants, unfortunately, probably did pass away during the study. You can see the median of about 2.5 years, so a reasonable amount of time to look at. But there's people who recruited right at the start of the study who had quite a lengthy amount of time, so sort of 4+ years of follow-up as well. So it gave us a really good opportunity to have a look over different time periods. So substance-related hospitalisation, so just under a third had any substance-related hospitalisation, so either a hospital admission or ED presentation. And then you can see there methamphetamine was the most prevalent, opioids, and then cannabis. Obviously, to contextualize that, given that such a small number of people with moderate to high risk for opioid use in that 3 months before prison compared to methamphetamines, for example, that 7% is actually pretty high. So that just goes to show the risks associated with opioid use, which are well established. And yeah, here's our table. Now, I've just focused on 6 months, which is kind of comparable to the previous study where we looked at that first 6 months, but obviously we've got data for the whole follow-up period, and so we looked at 3, 6, and 12 months. But by 6 months, there are probably the 3-month results. There's probably not enough events, as you can see from the confidence intervals there. They're quite wide. By 6 months, we've probably got enough events there to get some more precise estimates. And the unadjusted and the adjusted results are both really useful. Obviously, the unadjusted results tell us what the kind of difference is between the low and no risk participants versus the moderate to high risk. And then the adjusted results start to tell us a bit about why those differences might be there in terms of their demographics and their health profiles, etc. But yeah, the unadjusted findings, obviously, there's a pretty stark difference in risk between the low risk and the moderate and high risk group with respect to having a drug-related hospitalisation. And then you can see that risk does persist for a long time. So we saw there that the longest followed participant was about 4.5 years. But those risks, those differences in risk are still there, and they still persist even across the whole follow-up period, which goes to show that this is a sort of chronic and ongoing problem for a lot of people. So yeah, I did a forest plot just to kind of graphically show this. The 3-month period all the way through up to, as you go up the graph, all the way to the entire follow-up period. You can see there pretty clear results in the unadjusted, and then similar, but obviously more precise for the adjusted, as you'd expect. So yeah, pretty clear effect across the different drug types. We suggest that the assist discriminates pretty well between people who screen for low or no risk versus those screening for moderate to high risk. So what are the key findings from all of this? There's obviously been a bit of a rapid fire snapshot of some of the key outcomes of the study. So consistent with previous evidence and our data, prison serves to interrupt rather than cease harmful substance use. And as we've seen with the results I've just presented there, that risk tends to persist for several years after release from prison. So there are probably opportunities being missed, I'd say. Reducing the risk of harmful substance use after prison remains a key challenge to address. It's one that prison and prison health authorities have been grappling with for a long time, and it continues to be a problem. And part of that is it's not just about substance use. There's obviously a range of factors that contribute to substance use as an outcome and the associated outcomes, social determinants and disadvantage, and a range of things that we know people who go to prison tend to experience disproportionately. So really important to identify as early as possible during incarceration who's at risk of these outcomes and who requires who should be prioritized to receive support and treatment. So what our research shows and what previous research has shown is that the assist can be used during incarceration, and what as a tool for initiating or identifying people who may need treatment and initiating the treatment. But we're showing that it actually also can fairly accurately predict who's at risk of highest risk of returning to substance use, and even more seriously, hospitalisation after the release from prison. So the assist, being as simple and cheap as it is to administer and quick, really can be scalable and cost effective for use in prisons, and previous research has shown that. We're just adding to that body of evidence. So the assist crucially can be used to plan and target treatment at those who need it most. So more treatment options, particularly for methamphetamine use, are urgently needed. Now, this was something that comes up time and time again, that we currently don't have effective pharmacotherapy for methamphetamine use, and I know that there is work underway, and there has been previous efforts to try and test existing treatments to see if they could be applied to the methamphetamine use disorder. And to date, we haven't got any compelling evidence that any of those work. So really at this stage, all we've got is the psychosocial therapy, which has moderate, fairly modest efficacy at this stage. But obviously there is work ongoing there. And one of the key challenges here is that opioids, obviously, there's been a lot of research and development going on into producing very reliable and effective maintenance therapy drugs and things like buprenorphine and methadone, which are routinely used in prison settings these days. Unfortunately, that group who uses both methamphetamine and opioids, the efficacy is pretty low for those opioid treatments. So that group in particular is a group that is really challenging, and we're going to need to do a lot more work to try and come up with suitable options for treating them and reducing the risks of these poor health outcomes. So treatment that continues after release from prison is crucial. So obviously a lot of the results I'm reporting are in that period, sort of 3-6 months after people leave prison. That seems to be the sort of window where things go wrong most frequently, the highest acute risk. So initiating treatment and support before people get out, and then having that continuity of care, that really is the key. And that is shown in many studies now involving people who go in and out of prison. And I just thought I'd finish with a provocative question. How do we achieve this? Obviously a very simple question, but not so simple answers. So yeah, thanks very much for listening today, and I look forward to hearing some of your comments and questions.
Thanks so much, Craig. That was a very compelling question at the end there that you had, and I thought that it was a very interesting presentation. I'm not so used to seeing odds ratios that are that high. I think a lot of the things that we see, or at least some of the research that I've read recently, you see like a 1.5, which I mean it's still important to see if we have a significant relationship there, but it's very clear the kind of predictive ability of it slash of the assist tool slash also the kind of just risk overall of SUD after incarceration and risk of rehospitalization. So again, thank you. So I'd like to ask Rebecca to join us now, and also would like to hear her perspectives. Before we do that, just want to remind everyone in the chat to use the Q&A so that I can pick up your questions afterwards. So again, I wondered, Rebecca, if you had any thoughts that you would like to share about Craig's presentation before we get into the question and answers.
Yeah, thanks, Tom. Yeah, it was a great presentation. Thank you very much, Craig. It was a pleasure to supervise, Craig, I must say. Such a very clear and great body of work when you see it all together. And I think what has struck me from working with Craig is the dominance of methamphetamine in the prison system, which, as someone who's interested in methamphetamine research, I should have known about. But I think when we look at the research literature, a lot of it is focused on opioid overdose risk. And that's what Craig was referring to early on. And as he said, it's terribly important. So there's good reason for that focus. But because of that, you tend not to think too much about the methamphetamine use in prisons. And my first reaction to this was, well, is this just people who are using heroin or other opioids who are incidentally using methamphetamine? Is it that kind of overlap in the population, or are these just people who use drugs and there's a little bit of methamphetamine in there? But no, that isn't the case. A lot of these people are using quite frequently. They're injecting, I think it was 79% are injecting, as Craig said, really high rates of hepatitis C compared to the general population, similar to what you see with opioid injection. So, and high suicide rates. So significant harms, and also high levels of recidivism. And it does beg the question, what do we do about this? At the moment, we're struggling even outside of the prison criminal justice setting to work out what is the best way to provide treatment to help people reduce their methamphetamine use and to reduce harms related to methamphetamine use. But to me, it strikes me as an opportunity potentially to look to prison and say, well, we've got a lot of people going through prisons. And Craig has very nicely identified that the assist can be used to identify people who are high risk when they come out of prison for continued use and harms. I'm wondering if this is an opportunity that we should exploit to provide treatment and harm reduction. And while we might not have the world's ideal best treatments for stimulant methamphetamine use, we do have treatments for depression, and we do have strategies to reduce suicide risk. As Craig said, we've got the rollout of Hep C prevention in prison. That's a really good example of how we might be able to harness this as an opportunity to provide interventions. So I guess I'd be really interested to hear Craig's thoughts on this, whether he's got any ideas how we might use this as a way of providing interventions for people who use methamphetamine at the end of prison to reduce those post-release harms. But also another thing that has come up in this data is that very sadly, there's such an overrepresentation of people who identify as Aboriginal or Torres Strait Islander in prison. And that's really apparent here in the people who are using methamphetamine. So that adds another dimension to the situation. And I guess a more specific question I have for Craig is, how did the assist work with this population? Is it as valid as it is with people who are not from that Aboriginal or Torres Strait Islander background?
Yeah, it's a great question, and one that we tried to answer with some of the analysis. We tried to do some subgroup analyses for Indigenous participants and also for female participants, because I didn't really go into the overall demographics, but I think it's around 33 to 34% of our sample were Aboriginal across WA and Queensland, and around 20% were female, which is sort of actually twice what the actual rates are for female incarceration. It's usually around 10%, but we intentionally oversampled, for statistical power reasons. So long story short, even though we've got a large cohort, we just didn't have enough statistical power to generate estimates for those two subgroups. We did attempt to do that in that first assist paper that I presented, looking at the self-report follow-up survey data. But yeah, it is something perhaps with that expanded cohort, when we're going to have the 4 jurisdictions, that we can maybe have a look at trying to replicate the study, and we'll have a bit more power to do that, because it's very important that we know whether this does work for Aboriginal populations as well.
Yeah, that was one of the questions. I guess I thought maybe, reliability, when you break it down into subgroups, and the people that may have different health service needs, or different or disproportionately affected by certain outcomes. It'd be interesting to see if we can, if eventually you're able to get more power there, or someone else, as far as a larger cohort, to see that. Also wondering too, as far as like additional resources. So I'm pretty familiar with the LSI, and I believe that it was kind of somewhat routinely administered within New South Wales. And so additional resources that you think you could routinely administer with the assist in prisons in Australia, to maybe capture some more of people's needs potentially after incarceration.
Yeah, so I think the assist itself, which I believe South Australia may have used it at different times in their justice system, but I don't think it has really been routinely used anywhere else. I think it gives a really nice, simple, quick kind of snapshot of what people's substance use profiles are and whether they fit into those higher risk groups or not. And it's something that can be easily administered by like a nurse who does sort of health screening upon reception. And it would only take a few minutes, depending on how many substance people report using, because obviously you just ask the questions relating to the substances of interest. But for most people, we're talking like probably 3 or 4 minutes to administer. And I think given what we found, and if we do some future work on subgroups, it tells us quite a lot about who may need to be started on treatment as soon as possible, during their incarceration.
No, that's fantastic. Anything quick, I'm sure that clinicians, especially in the prison setting, would be appreciative of. We have a question from Penny who mentioned that in Victoria they see high rates of GHB, and whether or not the tool could capture this, and also asking why, or if you could confirm alcohol was out of the scope of your studies, and whether or not, I guess the assist could be used to capture that.
Yes, so I think we asked a category of hallucinogens, which I think GHB may fit into that class of drugs. I don't think we specifically asked about it, and there would be quite low prevalence in Queensland and Western Australia based on the data for hallucinogens as a whole. So even lower prevalence for GHB alone. But yes, the assist can be used. To specifically ask about GHB, you can ask about any substance that you like. And just remind me what the second part of that question was, please.
Regarding alcohol and whether or not that was, I know, I don't think it was presented in the tables that I saw.
No.
I could be wrong. Yeah.
Yeah. So obviously alcohol is the most prevalent substance, but it's not an illicit substance. A former colleague has done a similar bit of work using the audit, which is the alcohol use disorders identification test, which is also a World Health Organization tool. And then found similarly that it was very predictive of poor alcohol-related outcomes after prison. So we decided to not go down the path of redoing that work with the assist because the audit can be used for that purpose. So that's why we focused on the substances that I talked about today.
That makes sense. Thank you, Craig. So a question from Crystal, wondering, and so it's actually something that I was wondering as well, given the focus of the 3 months before incarceration, whether or not your research could broach drug use in prisons and help add additional perspective to your findings, and whether or not the assist would be useful there.
Yeah, so the assist has been used, I think, in some American jurisdictions to assess people for need of substance use treatment during incarceration. So yeah, it can certainly be used for that purpose. There are sometimes issues with getting people in prison to report their in-prison drug use because of the consequences of that in terms of, sanctions, etc. But yeah, in theory, we do have some data that we collected that wasn't included in what I presented today about use and injecting use during prison and previous prison sentences. So there is the possibility for us to do some more work on substance use patterns during prison as well.
Maybe you could provide more insight, and I could have missed it as well. Wondering if with that you would need to adjust the scale in some way just because of the availability of drugs in prison. So, for example, it's someone that may be using daily outside, that may be the threshold for some sort of indicator of some problem, but it may be a lower threshold in prison because of the availability. Is that part of the scale that you think could be, I don't know if it's adjusted is the right word, or?
Yeah, I don't know that work has actually been done, but it's a good point. And I think it's if the assist was going to be used as sort of a clinical guidance tool in prison, those sorts of issues would need to be addressed, and they probably would need to do some work. It's probably not been done because prison research is tricky and it's expensive and it's not politically very popular. But if we had the opportunity to do more in-prison sort of work, then all those sorts of questions are worth trying to address.
Sure. Yeah, no, absolutely. Well, I said that. I asked the questions. So a question from Tim saying that he didn't want to derail, which I don't think that this does. And but any quick comments regarding smoking during incarceration and on release, and whether or not I don't know if the assist would, it may be similar to the alcohol question where it's not an illicit substance, so maybe not captured within there. And we all know, I think we know that the smoking prevalence in prisons is quite, or at least I'm not in prison, but the population quite high smoking rates, if I'm not mistaken. So, any thoughts there?
Yeah, so the assist is routinely used for smoking because it's in the title, alcohol, smoking, and substance involvement screening test. We actually, our primary measure for tobacco was the Fagerstrom test. So we did administer that, so we have data on that. I would say in our population, smoking was normative, so that it was unusual for someone not to be a smoker in our sample. They were definitely in the minority. But having said that, a lot of jurisdictions across Australia now have banned smoking in prisons. WA hasn't yet. I think we're either the last or the second last, maybe. So, and I think they're trialing it currently in one of the female prisons here. So that the landscape around smoking has definitely changed with respect to prisons in Australia. But yeah, it would be interesting to know who goes back to smoking after they leave if they manage to give up whilst they're in prison.
Yeah, it's would be certainly interesting to see. And just on this note as well, Stuart had a question about whether or not you had any comments, and I'd be interested to get your thoughts, Rebecca, too, in regards to if you know anything about the availability of any sort of psychosocial or any sort of treatment in prison. But the fact that these scores are reflecting the 3 months prior to prison, and then these are they're predicting outcomes that are happening after prison. So it seems like there's an opportunity there where people are in touch with a system of some sorts, whether or not, I mean, there's pretty clear adverse health effects that we know, but there's clearly not a lot happening there as far as treatment goes, or as far as trying anything that could help or harm reduction goes, as far as predicting, using things from 3 months beforehand to predict what's going to happen after prison still. This could be years down the line.
Yeah, so it's the old adage that past behaviour predicts future behaviour, and behaviour change is difficult, as we know, just for people generally, but probably even more so for this cohort of people. I think one of the key challenges is that there's a real lack of human resources in healthcare in prison. Like, the health services are chronically understaffed, particularly mental illness and alcohol and other drug support services. And so a lot of the time people are managed using medications because that's the cheapest and only real available option. Whereas for something like methamphetamine use at the moment, it's psychosocial interventions that is pretty much all we have that have sort of modest efficacy. So if there's a shortage of staff, like counselling staff and psychologists, then of course those services aren't going to be readily available, or as available as they need to be, given the need that we've just highlighted here. So that's one of the ongoing challenges that prison health services face.
Rebecca, any thoughts there?
I think it is challenging, given what Craig said about the use of medications, and if people are going into prison, they might not be using regularly enough to even justify a pharmacotherapy. So it's not even a good fit. And yeah, I don't know a lot about what goes on inside prisons. I'm not an expert on that, but it is a challenge. I've heard anecdotally that mirtazapine is used a lot. We are trialing that for methamphetamine. Like I said, they might not be using when they're in prison. But I am wondering if there is some opportunity for medicating some of the depression that you see, for example, if there are pharmacotherapies that are indicated for both depression and methamphetamine. Hopefully one day one will be. So that might be useful.
Yeah, it's sort of, sorry, I'll just jump in there as well. We know that there's an acute and a subacute phase of withdrawal for methamphetamine as well, where people have symptoms like depression and sleep disorder and that sort of stuff. So yeah, it does, suggest that there are opportunities to try and innovate, particularly in this space.
I mean, the other option is, okay, maybe the resources aren't available within the prison, but when people are releasing them into some kind of treatment situation, so they're getting that follow-up care. They're not just going straight back into the community if they're at high risk of relapsing.
And yeah, definitely hoping some of your work, Rebecca, will help enlighten us as far as pharmacotherapies for methamphetamine dependence. I think that too, just to say, be one of the, I guess, I don't want to say guilty parties, but people that works in the more opioid related space. I think that may be part of the reasoning too, just because, as Craig, you noted, a lot of the expense and the difficulty of sometimes doing prison research, the easier quote unquote access of administrative data to opioid-related treatments, whether or not that has anything to do with the lack of, methamphetamine research, whether or not, eventually, if we do have pharmacotherapies, whether or not that will allow more research in that area, and hopefully also adding that to survey data from people who are incarcerated or released from incarceration. So I would love to answer all the questions that we have still lined up, but I think that if we get started on another one now, we may go a bit over time. So again, I wanted to thank Rebecca and Craig so much for your time, and Craig again for a wonderful presentation that covers such an important topic, especially here in Australia, given the burden of methamphetamine use overall, and particularly in prisons, which even Rebecca was surprised by some your your findings as far. So there's clearly something to learn for everyone as far as research. I know I learned a lot today, and I really thank you again for coming to present to NARC and to all of the attendees. So thank you again to everyone. I believe that there will be another, yep, here we go. So this is our next webinar. That will be next week on Thursday, April the 11th, and we'll have one of our, another NDARC a person joining us for the presentation, as Rebecca did this week. So Kendall with Malcolm Gillies, Dr. Malcolm Gillies from the School of Population Health on prescribed opioid use after hospitalization or emergency department presentation among opioid naive adults. So another interesting presentation coming up, and we will, there'll be a link, I believe, to register and join for that presentation. And thank you all for attending. Really appreciate it. Thanks again, Craig. Thanks again, Rebecca.
Thank you.
Thank you.